Welcome. On behalf of the International Cardio-Oncology Society, I'm Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, and today we present highlights of a recent ICOS webinar. Our highlights today discuss a risk prediction model for ICI myocarditis. Our presenter today is Joshua Levenson. Dr. Levenson is the Director of Cardio-Oncology at the UPMC Medical Center in Pittsburgh and directs the center out of the Shadyside Hospital in Pittsburgh, Pennsylvania. We want to make sure that you remember to set your calendars and attend the GCOS Summit this year, 2026, October 5th through the 7th in Williamsburg, Virginia. It's never too early to start making plans. And now on to our presentation.
Immune checkpoint inhibitor, or ICI myocarditis, is quite rare with an incidence of about 0.5% for those who receive a single ICI therapy. And for those who receive two ICIs, the incidence could be as high as 1.5%. In addition, the patients who get ICI myocarditis, many have very mild symptoms, many are asymptomatic, but as we all know, patients can die from myocarditis. And in the literature, for those who were untreated and unrecognized, the fatality rate has historically been described as 50%. And as a result, we are always looking for predictive models to figure out who is going to do well and who would not do well with conservative treatments, whether it's observation or other immunosuppression. There are pharmacovigilance studies that have been published, but there really are not great predictive models to know which patients who get ICI myocarditis are going to do well and who are going to be very sick or potentially die. As a result, the aim of this study was to determine those predictors of negative outcomes, and from there try to create a practical risk score that could be utilized by the average clinician to help understand who will have a negative outcome in patients with ICI myocarditis. One of the major, strengths of this paper was the ability to describe how these patients actually look like and how they get sick. And we've learned over the years that many have an overlap with myositis and or myasthenia gravis, and have recognized now that respiratory muscle failure is a major complication, even if the cardiac symptoms are relatively mild. So respiratory failure here was defined as having impaired ventilation and needing to get on ventilation, whether BiPAP or intubated. And then cardiomyotoxicity-related death was a complication from any of those clinical endpoints as described above that led to death. A number of covariants were then placed into the registry and used to help determine risk here. But the variables that were predictive were then utilized for a risk model. Those included, as you can see here, active thymoma, those who had a very short onset to symptoms, those who had cardiomuscular symptoms, which we'll talk about as predominantly muscle fatigue or weakness. And in my head, I think of those as symptoms of either myositis or myasthenia gravis. Those who had very low voltage were also a predictor, and certainly those who had a elevated or normal EF were actually predictive of poor outcome. The higher the troponin level was certainly a risk factor for a worse outcome. And then, as been demonstrated in a number of other trials, the risk of thymoma, again, was shown to be a major prognostic risk factor, and so was the value of this paper includes not only the risk factors for poor outcome, but understanding how these patients really die. What is the clinical representation of how patients suffer negative outcomes? Before we get there, we'll see this description of what cardiomuscular symptoms were described as, this in the supplemental data. Of the 748 patients, dyspnea, fatigue, weakness were actually the common symptoms described by the vast majority of patients who had ICI myocarditis. Chest pain was a small minority, roughly 18%, and myalgias included 15%. And so while myocarditis can present with classic chest pain, the symptoms of just being short of breath or fatigued or weak is actually the vast majority of the symptom complaints. A small minority did have dysphagia, cough, and for those clinicians out there, it's worth it to think of these screening questions in order to help identify patients, since they are a number of the descriptive factors for patients. The EKG features that have been described here have been demonstrated as well in other cohorts, such as ventricular tachycardia in a small minority, 5%, complete heart block in roughly 11%. Other rhythm or repolarization abnormalities are noted. Only a small number, 3%, had ventricular tachycardia and complete heart block, and some small conduction disorders in 12%. So patients with ICI myocarditis can have commonly PVCs, PACs, or just repolarization abnormalities, and the more severe forms are noted but are rare. Myasthenia-like symptoms and the myotoxicity were described in only 4% of patients, with 20% having myositis and then over 57% having no myotoxicity. And this matches previous descriptions of roughly 30 or 40% of patients having this overlap type symptom of ICI myocarditis, along with either myositis or myasthenia gravis. Circular line voltage criteria, small minority had a small LVH or low voltage criteria. It's unknown exactly whether that reflects, for example, pericardial fusion or other just myocardial inflammation that showed low voltage. But regardless, as you'll see, was a predictor for poor outcome. And then in those who had a endomyocardial biopsy, 2/3 did have a cardiac pathology was suggestive of myocarditis, but a third did not have it, even though they still met clinical criteria. So when patients were then analyzed with this cohort, we were able to find variables and utilize those to create a risk score. And this risk score is really described here based on that number of variables. They were utilized a point scoring system in order to really operationalize this for the average clinician, such that active thymoma was given 2 points, these cardiomuscular symptoms 1 point, a low voltage was given another, an EF that was low, less than 50%, another point. Then you can see here, based on the severity of the troponin elevation, 1, 2, or 3 points. And based on these number of points, it was predictive of those who would have a negative outcome that's been described as part of our primary outcome.
What an excellent discussion of the complex issue of ICI myocarditis and the evolving field and prediction of risk. I'm sure you enjoyed that, and I certainly enjoyed Dr. Levenson's presentation. If you're not yet a member of ICOS, you should go to our website and join the premier organization for cardio-oncologists throughout the world. So until next time, this is Dr. Tom Murtaugh saying, treat cancer, protect hearts.